So normal meniscus anatomy, we all know, it used to be considered vestigial, but then the papers which came in the 70s and 80s, which made people think about meniscus as which having an important function. So that was a paper in 2001 where 117 patients were followed up for 14 to 20 years, and they found osteoarthritis incidence of about 71%, where a meniscectomy was done, which was advanced in 48%, and where it was much lesser in the control group. So should all meniscus tears be repaired? No. Careful patient selection is the key. Less than 50% may be repairable, and that gray zone is tilting towards a repair nowadays. So when we talk about meniscus, you have to understand the hoop stresses, which increase the contact area and decrease the contact pressures, and which protects the knees. The load bearing would be just at the tip of the condyle, or the most prominent part of the condyle, if the meniscus was not there to transfer the load from the femur to the tibia. So the lateral meniscus offloads the lateral compartment by 70% and the medial meniscus by 50%. So lateral meniscus has a more important role. Talking about repairs, you have to know the vascular zones, the blood supply of the meniscus. Outer third is vascular, inner third is avascular, middle third you have to again decide on repairs depending on the period which has elapsed after the injury, and the irregularity of the edges and the vascularity of the edges. The blood supply is from the geniculate arteries. So the resection of the posterior horn of the medial meniscus increased contract stresses by 65%, and the total meniscectomy increases it by more than 200%. So partial meniscectomy without an intact peripheral rim or root attachment results in loss of normal hoop stresses, and it can act like a total meniscectomy. The meniscus, especially the medial meniscus posterior horn, has a break-stop function. So especially in an ACL deficient knee, the medial meniscus function and meniscus tears, the chance will be more. In lateral meniscus, it works as an important stabilizer, especially in the pivoting after an ACL deficient knee. These are the meniscus tear patterns: the longitudinal, the vertical, the horizontal tears, the radial tears, the parrot beak or the bucket handle tears. So acute knee injuries with an intact ACL, the medial meniscus is 5 times more likely to get injured, and acute knee injury with an ACL ruptured, the lateral meniscus is more likely to be injured due to the pivoting movement which happens in an absent ACL or deficient knee. So ACL previously injured, lateral meniscus is more injured, and repetitive deep squatting, the medial meniscus is more likely to get injured. So that is a MRI of a tear of the posterior horn of the medial meniscus. You have to understand the other findings. There may be the discoid lateral meniscus, the meniscus ossicles, which can change your treatment modality, the horizontal tears, the longitudinal tear of the posterior horn or the vertical tear, the radial tear, or the ghost meniscus sign, where the meniscus root has come off in the posterior part. In the radial tear, you can have the marching cleft sign. Reading an MRI is very important. Just don't go with the report of the radiologist. You have to sit with the scan, a good quality one, to look at meniscus tears and the patterns to know whether you can repair or stitch the meniscus before you go in, because mainly for financial matters and for rehab matters. That is a complex tear of the posterior horn of the medial meniscus. That is a displaced tear, a flap which has displaced with the medial intercondylar notch side, and that's a bucket handle tear where there is a double PCL sign. So the arthroscopic view, that is a normal meniscus, and you can see a longitudinal meniscus tear there. Undisplaced, which menisci are to be left alone, or tears have to be left alone. You can leave alone an undisplaced stable medial or lateral meniscus tear, which is usually less than 8 or 10 millimeters long. A short undisplaced stable tear, you can do a synovial abrasion, or a short displaced but stable tear. Again, you can do a trephination or something to increase the vascularity, and you can leave alone. Partial meniscectomy, tears which are not amenable to repair, parrot beak type tear, repair failure will be more than 2 times there. So remove the torn meniscus fragment. These work well, especially if it is involving only the inner zone of the meniscus. You can leave a balanced, stable rim of meniscus tissue unless it is going all the way to the rim of the meniscus. Partial meniscectomy is always preferred over total meniscectomy. Shorter operating time, faster recovery, and cost is also minimal in a partial meniscectomy. Repair, appropriate patient selection is very important. Documented tear that is liable to heal, repairability, that is the geometry we said, the technicalities which are available, the fixation methods, the biological manipulation and the healing potential, associated surgeries, especially along with an ACL reconstruction, the chance of a meniscus healing is much better. Patient preferred when the patient wants, because there are patients who come demanding for a meniscus, but then you have to counsel them well depending on the duration which has passed and the edges, and you may have to take decisions, and that has to be consent has to be taken from the patient. So the steps of meniscus repair: the tear debridement, the local synovial, meniscal and capsular ablation to stimulate a proliferative fibroblastic response, and suture placement to reduce and stabilize the meniscus tear. Risk of meniscus repair: the saphenous nerve and vein are nearby, especially the medial side, the peroneal nerves, the popliteal arteries. Why do meniscus repair? To restore the function, maintain the load transmission and minimize the contact stresses, contribute to stability and reduce cartilage wear, that is chondroprotection. Avoid repair when there is a chronic complex tear, a degenerative tear, especially in an older individual, an unstable knee without ACL reconstruction. The chance of re-tear would be around 30%, and associated grade 4 osteochondral lesions, or in older age. That definition changes mainly based on the physiological age of the patient, usually above 50 or above 45. Be careful when you think about meniscus repairs. The tear patterns which are amenable to repair are the longitudinal tears and even the bucket handle fresh tears. The horizontal and radial tears are potentially repairable, but the oblique parent beak tears or the complex degenerative tears are usually irreparable. The methods of repair: the anterior horn, we can go by the outside-in technique. The body tears, you can go by the inside-out technique, and the posterior horn always all inside unless the finance is too tight. So those are the meniscus repair devices with the anchors and the loops. There are all fiber meniscus repair devices by the companies nowadays, negating the anchor problems. That is a meniscus, medial meniscus ramp lesion. The ACL is deficient here. It's the left knee, and the medial meniscus, posterior body root junction. You can see the blood coming out, and that's a ramp lesion here, which was seen on the MRI, and that was repaired by an all-inside meniscus repair. The anterior horn, you can very well use 2 spinal needles and a loop of fiber wire, or PDS fiber wire 2.0 is quite good for anterior horn repairs. That's a horizontal tear which can be partially balanced, and the rent can be closed so that the fluid leaking and meniscus cyst, parameniscal cyst formation can be prevented. That is a significant parameniscal cyst with along with the posterior horn medial meniscus tear. You can see the meniscus slightly extruded, horizontal tear with a significant parameniscal cyst in the coronal and the axial views. That is a bucket handle tear. You can see the displaced fragment inside and the double PCL sign on the sagittal image. That is a bucket handle tear of the medial meniscus involving the posterior and body. And only a repairable one which is stable after reduction, you should think about repairing the bucket handle tear. You can see the vascularity in the edge. It was a young patient. It was done along with the ACL reconstruction. This was a posterior horn all inside repair with inside out, that is all inside device, and the inside out with the needles with loaded tape. For inside out repair, and the knot is tied outside. That is a medial meniscus root tear. Again, that is a root which is torn, and you can go with, I usually use a ACL jig to place a tunnel from the tibia, and fixation I do with an endo button or a suture disc outside. The area for attachment has to be cleared of cartilage for a good reattachment, and meniscus scorpion used for taking bites, a loop which is taken through the meniscus, and it can be pulled down into the tunnel to get a good tight repair of the posterior root of the meniscus. So pearls and pitfalls, preparation of the tear is a very essential step. Debride and abrade or trephinate. Reduce the tear accurately and maintain reduction during fixation. You can use a spinal needle which can help in maintaining the reduction. Hybrid techniques are useful, especially in displaced bucket handle tears. Accessory portals can improve access and fixation of the fixation configuration. The perpendicular placement of implant every 5 or 8 millimeters, up to 10 millimeters, you need one implant to fix. Grab circumferential fiber bundles to ensure optimal purchase strength. Ensure that implants are not too proud, either intra or extra-articularly. Avoid stuffing the knee with too many implants because they can cause stress risers and can produce separate tears because of the implants sometimes. Rehabilitation, again, individualize, protect, and protection and weight bearing are quite important. So now meniscus allografts, autografts, synthetic meniscus are all coming into the vogue. Take home, multiple factors determine repair versus resection, and goals of the patient is very important, and age. The medial meniscus is, if possible, a repair to maintain control of the contact pressures and to restore the break-stop mechanism. Meniscus functions to decrease the contact stresses and protect the knee. Meniscus helps to stabilize the knee, in particular in the setting of an ACL injury, and meniscus preservation is the key. Repair failure rates of at least 20-25%, more on the medial side, are expected, and meniscus surgery in a degenerated knee should be entertained only with extreme caution. Thank you.